Hello, let's talk about brain tumors. This SDL, you're going to have 5 questions from it. So you'll have one about probably a pilocytic astrocytoma or a subependymal giant cell astrocytoma. Both of those stain positive for glial fibrillary acidic protein, and they're also associated with a couple of autosomal dominant tumor syndromes, pilocytic with neurofibromatosis 1 and SEGA with tuberous sclerosis. So particularly test worthy, those two. I do think you'll see a test question about a glioblastoma, which has a very characteristic histology. It's called pseudopalisading. You know what that is. You recognize glioblastoma is an astrocytic tumor of adults. You got the question right. I think you'll see an oligodendroglioma question, another pretty easy recognition. That's the fried egg histology. And of course, oligodendrocytes, their function is to myelinate neurons of the central nervous system. And that's about all they could ask you about the oligodendroglioma. Now, the ependymoma, that's a tricky dude because that's a pediatric, what do they call that? Infracellular tumor. No, there's another word for it. It's a posterior fossa tumor. That's it. So there's more than one of those. So there's at least a differential for the ependymoma, including other stuff such as the medulloblastoma and the CNS PNET, right? So ependymoma, kind of tricky, likes to drop down the spinal cord. Understand you're going to see rosettes in the ependymoma. You might see some calcifications too. And then finally, the choroid plexus papilloma. I would not bank on a question about this one, but if you do, it's going to involve a fibrillary stalk or papillovascular core, something like that. It's going to have a fibrous core and stalks branching outwards from that core. That's the common architectural motif shared by all papillomas. So that's what could get asked out of this first cancer SDL. Let's go ahead and dig into the different tumor types. All astrocytic tumors stain positive for GFAP, that's glial fibrillary acidic protein. And the function of the astrocyte, recall, is that it forms the blood-brain barrier and very tightly regulates the entrance and exit of metabolites into and out of the brain. Now, the glioblastoma is a particularly bad tumor, a very common tumor amongst adults. It's a grade 4 tumor, so it goes downhill pretty rapidly. It is going to stain GFAP positive. It's got a characteristic histology we'll get to in a second. First, let's talk about a couple of astrocytomas that appear in children. The pilocytic astrocytoma being first. This is a cerebellar tumor. Median age at diagnosis is 13 years. Any cerebellar mass will present with ataxia. So a couple of well, first, what is ataxia? It's just a generalized discoordination of movement. And you can test for ataxia by seeing if the patient can stand on one foot. That's a good test of your balance, which cerebellum controls. Another thing you could do is do the old finger to nose to hand to nose to hand. And if there's any shakiness in the track of their finger as they follow yours and touch to their nose and follow your finger again, then you're going to be clued into the presence of a cerebellar pathology because your cerebellum coordinates the smoothness of movement. So if someone is unable to really go in a straight line, but they're a little shaky, it's a cerebellar pathology. Now, kids' tumors do like to be in the cerebellum. They like to be infratentorial or underneath the tentorium. And the cerebellar is that and the brainstem are the only parts of the brain below the tentorium. Now, these pilocytic astrocytomas, they're called pilocytic. That just means hair-like. So, bacteria have fimbriae and pili, right? And what are those? They're just like little finger-like strands of hair that stick off the bacteria to coordinate its movement. And that's exactly the same motif that's going on with this astrocytoma. It looks like it has hair. So even in black and white, you can tell that these are long strand-like processes popping off of these cells. By the way, I keep my SDLs in black and white just to cut down on distractions because otherwise there's just too much red, blue, and yellow popping off all over the place. So the Rosenthal fiber is a characteristic finding of the Pilocytic Astrocytoma, and they're brightly eosinophilic. And that's about the last thing that you would want to know about the Pilocytic Astrocytoma, besides the fact that it's heavily associated with neurofibromatosis type 1, which is an autosomal dominant disorder. And I'd like to tell you a couple of pointers about autosomal dominant inheritance. First off, diseases that are autosomal dominant tend to present later on in life, sometimes even in adulthood. And the reason being is that, picture it's 500 BC, right? And your child is born with an autosomal dominant mutation. Let's say it's pathologic, it's deleterious. Well, if it's bad enough, then your kid's not going to make it very long if it's autosomal dominant, you know? And so that autosomal dominant mutation, then that's not going to last very long either. You know, if little dude is dead by the age of 5 or something, that gene is not getting passed on. And so all the autosomal dominant mutations that killed someone early on in life, in childhood, all of those autosomal dominant genes just died out. So the only autosomal dominant genes that are left are those that don't kill you immediately. Now, think about something like autosomal recessive. What's a good example of that? Sickle cell disease. Okay, you have sickle cell disease, you're going to know by about age 2 or 3 that you have sickle cell disease. Something else could be cystic fibrosis. If you have cystic fibrosis, you can tell within the first year of somebody's life that they have cystic fibrosis. Those are autosomal recessive. Autosomal dominant, something like neurofibromatosis, well, you might be in your 20s or your 30s before neurofibromas start popping up. One more thing that's important. Autosomal dominant diseases tend to involve structural proteins. I don't know why. It's just a thing. It's a thing. And then autosomal recessive diseases tend to involve enzymes. It's that simple, really. And channels, ion channels too, I would say. But these autosomal dominant diseases, neurofibromatosis, well, you have a structural protein malfunction. And so you get structural problems. You get skin nodules. You get hamartomas in the eye. These are all kind of connective tissue disorders. With tuberous sclerosis, which we'll talk about shortly, you get these, again, connective tissue bumps. Structural proteins get mutated. And then there's Marfan syndrome too, you know, that's classic. Fibrillin, that gene's messed up, and you're going to have arachnodactyly, lens dislocation, cystic medial necrosis of the aorta. And so again, that's a structural protein that's mutated there in Marfan syndrome. So autosomal dominant diseases tend to have structural proteins mutated. Now, this is neurofibromatosis type 1, which is associated with pilocytic astrocytomas. Here in the bottom left of this image, you're looking at hamartomas inside the iris of the eye. There are those little brown spots, and we call those Lisch nodules. And so this is a very popular way to ask a question. Anytime there's a tumor syndrome, it's easy to give you one tumor and then say, well, what else do you expect to see amongst somebody who carries this syndrome? And so the question would be, they give you pilocytic astrocytoma. It's easy to diagnose. It's GFAP positive. It's got Rosenthal fibers in it, like duh. But then they say, what else would you see in this patient? So then one answer would be maybe pigmented iris hamartomas. And then another answer would be something from NF2. So like bilateral acoustic schwannomas. So you'd have to remember that this particular cancer is associated with NF1, not NF2. That's how they ask the question. Back to the pilocytic astrocytoma. Here is a practice question. 8-year-old boy has recurrent morning headaches with nausea and vomiting. You're going to take an MRI, and here's what it looks like. First off, diagnosing brain cancer in a question stem is never difficult. They tell you that the patient has brain cancer. They show you most cases. Second off, how to read an MRI. Well, there's a lot of different MRIs out there. There's T1, T2, and FLAIR. And if you're like me, then you usually forget how to tell apart the different MRIs. And heck, most of the time, they don't even give you the particular weight that is being used in the image. So the way to orient yourself on an MRI is to find the bone and figure out if bone is going to be light or dark. And then that's going to tell you whether or not that's going to tell you what the density is for that MRI. And so if you look at this image, the bone's light. And then these sinuses, maxillary sinuses filled with air, they're dark. So that's how you understand, okay, the less dense an image is, the darker it's going to be on this MRI. So then we look at the cerebellar mass in this image, and we notice that it's darker than the surrounding cerebellum. And so we say, okay, this is a lower density mass than the surrounding brain tissue. But there is this kind of shiny part right there that is pretty hyperdense. So you're not dealing with an entirely solid mass here. Because most of it is hypodense, you get the feeling you're dealing with a cystic mass. So something like a brain abscess could be in your differential, but then you go to the question stem and it's nothing but brain cancers. So they're essentially asking you which of these brain cancers presents with a cystic mass. So it's a kid. Immediately you can rule out glioblastoma, that's an adult cancer. You can rule out pinealoma because you know that that's going to be above the tentorium, and this is a cerebellar mass. So that leaves you with ependymoma, medulloblastoma, pilocytic astrocytoma. So to answer the question, you must understand that the astrocytoma does have a cystic component to it, whereas the ependymoma and the medulloblastoma are solid tumors. Here is a sagittal slice of a pilocytic astrocytoma. Again, notice it's cystic with a hyperdense little nodular, almost a calcification, but largely this is an encapsulated cystic tumor. Here are the neoplastic cells. Notice the hair-like processes. Here are the Rosenthal fibers, outlined in green here. They are very eosinophilic, and they're essentially clumps or aggregates of intermediate filaments within the cell. Intermediate filaments are just the cytoskeleton of the cell, kind of like how your house has a frame to it. That's what these intermediate filaments are. They're keratin and vimentin and desmin. And so whenever there's a lot of oxidative damage inside of a cell, its frame is going to start falling apart. And so the vimentin, the desmin, the intermediate filaments inside the cell, they start accruing damage and just clumping together as they get damaged. So normally your cell's going to ubiquinate these proteins and send them to the proteasome, which is basically the wood chipper for all cytoskeletal components. But when the damage outpaces the rate at which you can get rid of these proteins, they back up. And so you get these aggregates that are known as Rosenthal bodies in the pilocytic astrocytoma, but you can also see them in the liver in the setting of alcoholic liver damage, and then they're called Mallory bodies. So this will pop up again with the intermediate filaments. We looked at NF1. Here's a couple more images of the pilocytic astrocytoma. Notice your Rosenthal fibers. And look, this is a pretty easy point and click diagnostic question. They tell you it's GFAP positive. They show you the fibers. They show you the cyst. What more could you want? Another astrocytoma that grows in children, young adults, is the subependymal giant cell astrocytoma, or the SEGA. Now, this tumor does have a particular location inside the walls of the lateral ventricles. Here is an example of a SEGA, 3 different ones actually, just popping into that lateral ventricle on the left side there. And you can tell that it's starting inside the brain parenchyma and going into the ventricle, as opposed to starting in the ventricle and going into the parenchyma. There is a difference. Lots of tumors do start inside the ventricles. So if you were to look at the SEGA under histology, well, it's called a giant cell astrocytoma. Big surprise, here's a giant cell. Looking very similar to an osteoclast. Here's another one right on top of it. So you got 2 giant cells back to back. Here's maybe a third up here that could qualify. And if they don't show you an image with any giant cells, then there will at least be some polygonal cells. You know, polygonal just means many-sided. So like this right here, 1, 2, 3, 4, 5. That's a pentagonal cell. Yeah, that's a standard geometric shape. So that's what you see in the Sega, as well as some spindle cells. And a spindle cell is going to be anything that's kind of shaped like a pair of lips, you know, that kind of has a point. That's a terrible pair of lips, but a point on either end. And if it's got those two pointy ends, we refer to those tips of the cells as spindles. So when you see spindle cell, for example, a fibroblast or a smooth myocyte, that's exactly what that is. Now, what you really want to know about the subependymal giant cell astrocytoma is its association with tuberous sclerosis, which is another autosomal dominant inherited tumor disorder, tumor syndrome rather, in which you see hamartomas popping up all over the body. Now, they're very prone to cause seizures due to their location in the brain, and that should make sense because if you just get this dense fibrous nodule in the brain, it's going to disrupt the flow of electricity around it, and that's all that a seizure is an anomaly in the electrical conduction of the brain. But not only do you see them in the brain, you can also see them in the heart and in the kidneys. You can get cardiac rhabdomyomas, these angiomyolipomas, that's a renal tumor. And so, easy question there is going to be, what's the protein that comes from the gene that is mutated in this patient with this subependymal giant cell astrocytoma? And the answer to that question is either going to be hamartin or tuberin, okay? Because those are the two possible proteins involved with the two genes that you see in tuberous sclerosis. Then there's the pleomorphic xanthroastrocytoma, not much to say there. I will add in at this point that in your in-house pathology exams, they don't really like to test about the subtypes of individual cancers. They are more so interested in, can you tell this cancer apart from that one, okay? So don't read too far into the, oh, this is subtype A, B, C, D. No, it doesn't matter that much. The diffuse astrocytoma, now we're in adult tumor territory. The diffuse astrocytoma is a precursor to the glioblastoma, which is really the one you want to know. You're going to get a test question about glioblastomas. So quickly, let's discuss the diffuse astrocytoma, that precursor to the glioblastoma. It's got fibrils. It's got a hairy fibrillary pattern, kind of like the pilocytic. It's got elongated processes, kind of like the pilocytic. But unlike the pilocytic astrocytoma, the diffuse astrocytoma has microcysts. That's the word, the image you want to look out for to let you know you're dealing with the adult astrocytoma. And of course, it'll be positive for GFAP, glial fibrillary acidic protein. Now that's the precursor to the glioblastoma, which is the one you really ought to be able to recognize like the back of your hand. The glioblastoma, because it is such a malignant cancer, there's a high degree of necrosis. And so then cells will start to line up around the border of a necrotic zone where there's just enough perfusion for them to live. And that's going to appear on histology as palisading. Here's a glioblastoma, typically a cerebral tumor of adults. Can grow pretty large, pretty fast. This is a palisade, which is like some sort of Revolutionary War fortification. And all that it means to be palisading is that there's a bunch of objects lined up parallel to one another, perpendicular to the ground. So that's a palisade. Now look at these cells involved in this histology and tell me if you can't see a little palisading going on there, right? It kind of looks like they're all just standing side by side parallel to one another. And if you were to go look at this one, for example, that's just blatant. I mean, there's this necrotic core, and then around that core, there's a bunch of cells arranged nearly parallel to one another. And that's what it means to have a pseudo-palisading histology. And you will get a question with a glioblastoma, and there will be an image involved, and it'll look really similar to this. It might even be this identical picture, and you're just going to click glioblastoma and move on, because that's all you need to know is that there's a P53 mutation, and it's called glioblastoma, and it's got pseudopalisating histology. Here's a question. 40-year-old man shows up to the doctor. He's having difficulty articulating when he speaks, and he has worsening headaches associated with nausea and vomiting. You do an MRI, you see a brain mass, you take a stereotactic biopsy, and you see this histology. What do you see here? I see this kind of swath or field of necrosis. And then around the necrosis, I see a lot of nuclei arranged so that they're kind of side by side, single file next to one another. So that's a pseudopalisating histology, classic for glioblastoma multiforme. That's exactly how that question gets asked. You do want to know the P53 mutation is the defining mutation of the glioblastoma. And I added in that Li-Fraumeni is the name for the familial cancer syndrome in which P53 mutations are inherited and passed down from parent to child. If you see anything about isocitrate dehydrogenase, what's important to know is that that messes with the epigenetics of a cell, and it's going to turn certain genes on, certain genes off. CpG island methylation, that's what that means. You know, to methylate a gene means to silence it. Then we have the Oligodendroglioma, which also has a characteristic presentation. If you, like me, enjoy making a good breakfast in the morning, you're going to spend about 5 seconds on this pathology because the histo looks like fried eggs. Now, I prefer 3 eggs, but sometimes I'll make 6, and I'll usually just scoop out the yolks because you don't need 6 egg yolks, you know. But at the same time, egg yolks don't kill you either, you know. It's like people who are like just the whites. It's like, what are you so afraid of, man? A little fat. So eat the egg yolks. There's a lot of good stuff in them. Now, these are fried eggs on histology. I really don't need to say anymore. You've got 2 eyes. You can remember that this is the only brain tumor that has this blown up fried egg appearance. Here's what it looks like on a scan. It's going to be a cerebral tumor, usually in adults. And here's a question. A 59-year-old man presents with severe headaches that are worse in the morning. There's a mass in the left frontal lobe on MRI. So you take a biopsy and you see this histology. So you should be thinking, wow, those are pretty round cells, but at the same time, they've got a good amount of cytoplasm to them. I think they kind of look like fried eggs. So what's the question here? Well, the question is, what's the function, the normal function of the tumor cells seen in this histology slide? And friends, I want to tell you, they can ask this question, this exact question, for any brain tumor. So in the case of the oligodendrocyte, what does that do? Well, that myelinates neurons in the central nervous system. So there's your answer. As far as genetics go, co-deletion of 1p and 19q may show up on your test, may not. So the glioblastoma multiforme and the oligodendroglioma were both adult tumors. Now we're getting back into what's usually a pediatric tumor, the ependymoma. So the cell of origin here is the ependymal cell. And because ependymal cells line your ventricles, this tumor grows into the 4th ventricle. So if you have a mass slowly growing larger inside a ventricle, eventually, understand, you'll get a hydrocephalus. And it's going to be a non-communicating hydrocephalus because the flow of cerebrospinal fluid around those aqueducts and ventricles will be totally obstructed. So patients' heads typically swell up a little bit, especially if they're young and their skulls are still kind of pliable. And then after that, you're kind of at risk for herniations if you don't put a shunt in and correct all that fluid inside the ventricular system. So that's how ependymomas like to present, because they are ventricular tumors, particularly inside the fourth ventricle, which remember is right next to your cerebellum, correct? And say your pons right around there. So the ependymoma stains for GFAP, the same thing that astrocytomas stain for, but then it also stains for S100 protein, which is something that cells of neural origin like to stain for. So that can kind of complicate the ependymoma diagnosis. You might start thinking it's something else. I wrote down a note. I kind of do remember a question along the lines of this tumor, they show you the tumor. So they take out the tumor and maybe it's cut, right? So maybe they'll give you a gross image and then they'll tell you with words what the histology looked like. And then the question is, this tumor was most likely found in which of the following locations? And so it'll be like lateral ventricle, fourth ventricle, cerebrum, cerebellum, dura mater, something like that, okay? And so in this setting, it's going to be fourth ventricle. So the ependymoma, childhood tumor of the fourth ventricle. Let's get into some specifics on histology. First of all, it's got a fibrillary background. It's got a connective tissue background, okay? The words fibrillary matrix there mean a lot. It sometimes displays calcifications. That also means a lot. Not a lot of tumors calcify, especially not in the brain. So the fibrillary matrix is particularly important to ependymomas because that's going to help you differentiate it from the medulloblastoma, which is a small round blue cell tumor of neuroectodermal origin that does not have a fibrous background prominent throughout. However, the ependymoma does. And let me tell you why you need to differentiate the ependymoma from the medulloblastoma. It's because both of them show up inside the fourth ventricle, inside the cerebellum. And both of them can cause a hydrocephalus and present the exact same way. Furthermore, both of them have the tendency to drop straight down the central canal of the spinal cord, go down into the cervical or thoracic or lumbar spine in a process that's known as drop metastasis. So both the ependymoma and the medulloblastoma can do this. But we're not done. Both the ependymoma and the medulloblastoma have rosettes. So I'm going to kind of take a hard right now. I prepared a slide for this specific occasion talking about rosettes. I kid you not. I have seen the question. They tell you it's a child with a cerebellar tumor that's growing in the fourth ventricle, and they might show you a little bit of the biopsy, but all that they're going to show you is that there's rosettes. They're not going to give you any more information than that. They're not going to tell you what it stains for. You can forget about it. They're not going to give you words to describe the histology. Forget about it. You're on your own. It's just you and this cerebellar tumor and these rosettes. And you're going to get the question right if you know which rosette goes with the ependymoma and which rosette goes with the medulloblastoma. Okay? So it's actually pretty easy. If there is a big hole in the middle of the rosette, it's an ependymoma. Look at this photo. You see these rosettes, right? A rosette is just cells around a blank space. So there could either be something in the middle of that blank space, or there could be nothing. Okay, that's the difference. In an ependymoma, there's nothing in the middle of the hole. There's nothing in the middle of this rosette. So like right here, you can see white. You can see the other side of the slide. You can see all the way through. Same thing here. This is a blood vessel. Well, there's nothing in the middle of that blood vessel. So this is a perivascular rosette. And these two in the upper left, on the left and upper left side of this image here, these are true rosettes in which there's nothing in the middle. You can see straight through to the other side. Okay, that's an ependymoma. You got that? Now check this out. This medulloblastoma, look at these rosettes. There's junk all up in the middle of them. Every single one. Can you see straight through to the other side of that? I can't. You know, if the last one was Swiss cheese, this is American. This is like Kraft singles right here, okay? The lumens of these rosettes are completely filled in with tissue, with neuropil, with whatever you want to call it. Point being, they're not empty, they're full. That's a medulloblastoma. That's the rosette that you see in the medulloblastoma. And that happens to be called the Homer Wright rosette. Okay. So that's the ependymoma versus the medulloblastoma. What do they have in common again? Well, they're both childhood tumors that pop up in the cerebellum, specifically in the fourth ventricle, and they can cause an obstructive hydrocephalus, and both of them can even drop metastasize down the spinal cord. Very, very similar. Now, we did mention the ependymoma's got a fibrotic or connective sort of background to it. So let's get back up here and take a look at that. Notice that these are small, round, bluish cells, yes, but this is not a small, round, blue cell tumor, okay? It's an ependymoma. And the reason we know this is because, again, it's got a significant connective tissue component to it. Here it is grossly. You can see it right there in the fourth ventricle. Right there too, compressing the cerebellum so you can understand how this patient might have extreme difficulty, maybe standing on one foot or walking in a straight line, one foot in front of the other. Here's your axial scan. That thing's huge on the left here. So even though it starts in a ventricle, these can also start in the lateral ventricles. As you see on the rightmost image, it started in the ventricle and it grew into compressing the surrounding brain parenchyma or subcortex. Here's a drop metastasis. That's a very that's a very obvious metastasis there on the rightmost image. Sometimes it's not obvious, you got to hunt for it, but just understand if they're showing you a spinal cord, that's the point they're trying to make. The ependymoma, again, what's the cell of origin? Here's a good look at it. These ependymal cells line the ventricles, okay? So when we're talking about where does this tumor come from, that's where on the left-hand side of this screen, you're looking at the central canal of the spinal cord. So can you see, can you understand very easily how a little chunk or bit of a tumor might just break off of that larger mass and fall down that central canal, kind of like pinball, and then make its home in the C-spine or T-spine. One more time, those rosettes inside the ependymoma histology, they are empty. They are true rosettes. Either that or they are perivascular rosettes. Either way, there's nothing in the middle of them. Then you compare that to the medulloblastoma that has these rosettes with a neuropil in the middle. They're full in the middle. Those are called Homer Wright rosettes. So that's the ependymoma. Notice the effort put into this SDL in order to convey the difference between various rosettes to you. You will see a rosette on your exam. Guarantee it. Here at the bottom of page 14, they're telling you if you see something with the rosette, here's the differential diagnosis. So it's like A, Ependymoma, B, Medulloblastoma, C, CNS PNET, D, central neurocytoma. It's like they're telling you what they're going to ask. Again, one more time, you will absolutely see a spinal cord drop metastasis question. There's only a handful of things it could be: Ependymoma, Medulloblastoma, or Glioblastoma. Got it. Important details: spinal intramedullary ependymomas are more frequently seen in the disorder neurofibromatosis type 2. So the one big characteristic of NF2 is the bilateral acoustic schwannomas at the cerebellopontine angle. That's just a Schwann cell tumor. The Schwann cell functions to myelinate the peripheral nervous system. And if one of those turns cancerous, right there at the cerebellopontine angle, you're going to get some deafness, some sensory neural hearing loss. And that NF2, that's really all you want to know about it. NF1 has a lot more different presentations than NF2 does. But again, it's autosomal dominant, so it likes to present later in life, and it involves structural proteins. Okay. Finally, the choroid plexus papilloma. Again, say thank you if you get this question. It's so easy. What's the cell of origin? Well, the neuroepithelium lining the ventricles, also called the choroid plexus. So these are the cells essentially that create cerebrospinal fluid and push it into CSF circulation. Now, right here is all you need to know to answer this question. There is a fibrovascular stalk on this tumor because it's a papilloma, which is a motif, okay? It's like a theme, you know? You can have many different books across time that all have the same theme, okay? So like stand up and be a hero, you know? It's like that theme has been in human history since Gilgamesh, you know, since Beowulf, but like stuff that's written today. The Avengers, you know, it's like, what's the theme? Stand up and be a hero. Okay, so that's a motif. And you can see the same thing in histology. It doesn't matter what cell it is in or whose body it's in. You know, a papilloma is a papilloma is a papilloma is a papilloma across time and space. That's why we call it a papilloma, because it presents consistently. So every papilloma you'll ever see has a stalk. That's what I'm getting at. And in this case, the papilloma also has these cuboidal epithelial cells that make CSF called the choroid plexus cells. And so because it's in the ventricles, hydrocephalus is a common presenting symptom. And that is all you're going to need to know about the choroid plexus carcinoma or papilloma. So that's brain tumors 1. Let's kick it with brain tumors 2 a little bit. How do you feel about that? So looking at this, trying to remember questions from this SDL. Number 1, you will see a meningioma question. I guarantee it. Guarantee it. Number 2, I believe I remember getting asked a question in which maybe the patient had a primary lung cancer and it went to the brain, and then they wanted to know what part of the brain did the metastasis hit first. And the answer to that is the gray-white junction, okay? So gray matter, you know, demyelinated, white myelinated, and your cortex is demyelinated usually, and your subcortex is myelinated. And so right at that margin, that's where all metastasis gets first dibs at the brain, because that's where the blood-brain barrier is the thinnest. That's where it has the most perforating blood vessels. What else? The medulloblastoma, you will get a question about medulloblastoma. I believe that's the most common childhood CNS tumor. So after that, all bets are off. I would postulate you'll get 1 from this neuronal and glioneuronal section. And then I would say you might get like an ATRT, maybe, or a primary CNS lymphoma, maybe. but I'm not certain about that. I am certain that you're going to see a medulloblastoma, a meningioma, and a primary mets to the brain, which is, by the way, the most common brain cancer. Not primary brain cancer, but secondary metastasis from a different primary organ. So let's dig into this second SDL. We talk about neuronal and glioneuronal tumors. Understand neurons are cells that are typically just stuck in G0. They do not divide. And because they do not divide, we really don't see neuronal cancers. It's extremely, extremely rare. So when we do, it's typically in children, because these are going to be cancers that developed in utero and then presented early on in life. So glial, you know what that word means. That means the supporting tissue of the brain, aka any cell in the brain that is not a neuron or an immune cell is a glial cell. And every tumor in that first SDL was a glial tumor. The astrocytoma, the astrocyte's a glial cell. The oligodendrocyte is a glial cell. But now we introduce glioneuronal tumors, which are part glia, part neuron. So anything that is of neuronal origin will stain for synaptophysin and chromogranin A and neuron-specific enolase. That is super important. If they give you a test question and they want you to label it a neuronal tumor, then they're going to tell you it's chromogranin A positive, NSE positive, NFP positive. And this will pop up again in the kidneys, because you'll see that the adrenal glands of the kidneys, well, those are just neurons, essentially. Those are sympathetic ganglia. And so any adrenal tumor of the adrenal medulla, if that starts growing, then that's of neuroectodermal origin. So it'll stain with the same stuff. So remember these markers. Now, a ganglioglioma, the ganglio part means neuron, the glioma part means glia. So ganglioglioma has the best of both worlds, but a gangliocytoma is a pure neuronal tumor with no glial component. So if they want to ask about that, it's going to be an easy vocabulary question. What else could they ask? Well, they could give you the neuronal tumor and say, what else does this patient most likely have? And the answer to that question is going to be, the patient probably had a neuronal migration abnormality when they were younger, something like a lissencephaly, remember, with a smooth brain, or a polymicrogyria, correct? In which neurons were supposed to, kind of like football, all right? Like, you're running the seam, you're going to cross it, the 10-yard mark, okay? Now break. If your wide receivers are trash, it's like, I guess it's time to go out of the pocket. So that's kind of like a neuron migration disorder. Your receivers are supposed to run routes, and they're not running the routes they're supposed to. So that's what you would see alongside a neuronal tumor. What does it look like? Well, big surprise here. You see neurons, and they look exactly the same as neurons do in the peripheral nervous system. They're big and bulky foremost, okay? They are much bigger than surrounding cells. And then because they're myelinated, right? Neurons have an axon, and that axon is myelinated, and that helps us conduct electricity in a timely manner down that axon, like instantaneously. So where the fat gets washed out when you prep a histologic slide, that's where a neuron is. So you can tell, here's this big blank circle right next to this big fat cell. Well, the big circle is where there used to be myelination. There used to be myelin there, but there no longer is. And so now you're just looking at the remnant of the myelin around the nerve cell itself. So this is a gangliocytoma with no glial component, just some neoplastic ganglion cells or neurons. Then we discuss the central neurocytoma. I think this is easy to summarize. It is the only small round neurocytic tumor you're going to see in the ventricles. The ganglioglioma, the dysembryoplastic net, those pop up in the cerebrum, okay? in the functional tissue of the brain. But this central neurocytoma has a characteristic location in the lateral ventricles. So you will see small round blue cells inside the ventricles. And here on the left-hand side of this panel is your central neurocytoma. Notice it's just a bunch of small clustered cells with very dense nuclei, and it's arranged in sheets, okay? So this is what a sheet looks like, going back to themes or motifs, you know. This is a sheet of cells, and what that means is that they kind of fit together like graph paper or puzzle pieces. That's how well these cells fit together. They look practically solid. So then there's the Dysembryoplastic neuroepithelial tumor. And what's characteristic about this is that you see big pools of mucin inside this tumor. You really want to know what mucin looks like. This theme or motif within a tumor is going to come up again in the GI tract, where you have lots of goblet cells that produce mucus, and in the pancreas, which just does nothing but secrete all day. And you can see many mucinous cysts in the pancreas. So get used to identifying mucin on a histology slide. It's the only tumor in either SDL that has any mucin. The BRAF oncogene, if you see mucin, it's the BRAF oncogene. Okay. Now let's talk about the medulloblastoma, which is the most common malignant brain tumor of childhood. These tend to be cerebellar. They like to project into the fourth ventricle. Therefore, they commonly cause hydrocephalus. And they do like to drop metastasize. So if you see a drop metastasis in a kid, it's a medulloblastoma until proven otherwise, because that's the most common cerebellar tumor. And remember that what really differentiates the medulloblastoma from the ependymoma is going to either be the stain, because the medulloblastoma could be positive for a couple different neuronal markers, and the rosettes, because you see Homer Wright rosettes in the medulloblastoma that have filled in cores. They're full, right? Whereas in the ependymoma, you saw perivascular rosettes. In the medulloblastoma, we're seeing filled in cores. Now, as far as genes go, you probably want to remember Sonic Hedgehog. That's a good one. But other than that, it says that the other genes are in like 10%, 15% of medulloblastoma cases. So what that means is that they're not going to ask you about that, you know, if it's only in 10% of cases. What's the cell of origin? Embryonal. Wow, I can't talk. Embryonal. There we go. Embryonal precursor cells. Man, I had to really think about that, huh? Long day, eh? Of the cerebellum. So basically, you got these stem cells when you're a baby, and when you grow up, these stem cells are supposed to grow up too and become specific cells, but they don't in the case of this tumor. And so they just stick around, and they're these little baby cells dividing. Eventually you get a mutation in a tumor. And it likes to be in the cerebellum. Let's look at photos of the medulloblastoma. We've got a small round blue cell tumor similar to Ewing's sarcoma. And there's a rosette, there's a rosette, there's a rosette, there's a rosette. Rosettes all over the place. They are Homer Wright rosettes. So you can put a word with the image here, and they are totally filled in. You know, it's like that book Holes, right? You ever read Holes? With Stanley Yelnats, I finally found the right analogy. This is the analogy I want to use for this. All right, so you got these two rosettes, and this rosette is like Stanley Yelnats just dug a hole and then filled it back in with dirt. So there's dirt in that hole that you just dug. Versus the ependymoma would be like, you dig the hole, you know, it's got to be as deep as the shovel, as wide as the shovel, 5 by 5. You only get one canteen of water, and you just leave the hole in the ground. That's the ependymoma. It's just a big hole in the middle of the slide. That's a true rosette or a paravascular rosette. Versus the medulloblastoma, you dig the hole, you fill it back in with dirt. There we go. Now I won't forget it. A practice question, 5-year-old girl at the ED with projectile vomiting and a severe headache. So the projectile vomiting means papilledema, means increased intracranial pressure. She's had trouble walking for a few months now. No fevers or nuchal rigidity. You rule out meningitis. Negative for seizures, but notable physical examination for truncal ataxia and papilledema. MRI reveals a mass as demonstrated in the lesion. So this is a homogeneously enhancing mass right in the middle of the cerebellum. And it's of relatively similar consistency to the surrounding tissue. So we're going to say that this is a solid, not a cystic mass. And because it's a solid cerebellar mass along the midline, what's the most common solid cerebellar mass in a kid's brain? Answer to that, medulloblastoma, most common. Guys, do not underestimate the value of knowing the most common causes of certain pathologies. It can save you on a lot of questions. And I've gotten so many questions that only ask, what's the most likely cause of this presentation? And then they'll give you, for example, 5 causes of low platelets or of a prolonged bleeding time or whatever. And you have to know what the most common one is, because that's all that they'll ask you sometimes. So most common gets you very far. Pay attention when you see that. What's the question here? Well, what do you see on histology? Yeah, we know that you know the diagnosis is medulloblastoma. What's that look like? And the answer is going to be small cells, high nuclear to cytoplasm ratio, and neuropil. Those are those Homer right rosettes that are just holes with the dirt put back into them. Okay. Another look at them here. You've seen that before. Spinal cord, just a reminder, this likes to drop metastasize. So you see a drop metastasis, medulloblastoma until proven otherwise, because it's most common. Another example, these are pretty tumors, by the way. I mean, these are very aesthetic tumors, these medulloblastomas. Like a Rorschach test for doctors, you know, like if you don't see anything here, you're not a pathologist. You're a PCP. Let's get that straight. But if you look at this and you get goo-goo-eyed, well, we might have a radiologist or something on our hands. So that's a medulloblastoma. Now let's talk about the CNS primitive neuroectodermal tumor. I'm going to oversimplify this with good intentions. This is the same exact thing as a medulloblastoma, except you find it in the cerebrum instead of the cerebellum. That's really all I think you need to know about this. The ATRT, the atypical teratoid rhabdoid tumor, is called rhabdoid anytime you see oid, okay? That means like, but isn't. So rhabdoid means it looks like rhabdo, but isn't. So what's rhabdo? Well, that's in reference to the rhabdomyoma or the rhabdomyosarcoma, which are neoplasms of skeletal muscle. So what this is telling you is this brain tumor has a little part to it that looks like skeletal muscle. Let's check out what that looks like. You remember how in a myocyte, the nuclei get pushed to the periphery of the cell because inside the cell is nothing but, actin and myosin and those filaments in sarcoplasmic reticulum. There's no room for the nucleus. You don't want it in the middle. The job of the cell is to contract, get that nucleus to the side. So same thing in this tumor. Notice that the nucleus of this cell in the rightmost blue circle is just right at the periphery. Same thing here. All 3 of these circled blue cells, the nucleus is kind of pushed to the side. So that's why this has the name rhabdoid, okay? Here is a brilliant example in the very middle. Let's circle it in green. Look at how the nucleus to this cell is just right there on the edge. It's living on the edge. So that's why this looks like a myocyte. The ATRT has that characteristic histology, likes to present in the posterior fossa, right? So the cerebellum. And they consist of a combination of many cells. And so it's very tough to determine the cell of origin. They won't ask you that for this. All that they would really ask you is just, can you make the diagnosis if given the proper histology? The primary CNS lymphoma. I want you to understand that a lymphoma is a cancer of white blood cells. Next, I want you to understand that lymphomas and leukemias are both white blood cell cancers. And the only big difference in those two terms is where the cancer is. If the cancer is in the bloodstream or the bone marrow, we call it a leukemia. But if the white blood cell neoplasia is not in the bloodstream or the bone marrow, if instead it's localized to a lymph node or a particular organ, then we will call it a lymphoma. So I want you to understand that the cell of origin in a lymphoma is the lymphocyte, the B cell or the T cell or maybe the pre-B or T cell. So you know all about lymphocytes already. So the lymphoma is just a lymphocyte cancer. It's a lymphocytoma. Now, see if you can put one and one together and make two here. The primary CNS lymphoma is almost uniformly associated with Epstein-Barr virus infection. You know what that means? I'll tell you what that means. Epstein-Barr virus is a DNA virus. It's double-stranded and enveloped. It's not naked. And it infects B cells. Oh, okay. So this virus infects B cells and it plays around with the genome inside B cells. And then all of a sudden, later down the road, you get a B cell cancer. See how that happened? So hopefully that makes a lot of intuitive sense to you. The cell that gets infected is going to be the cell that develops the lymphoma or the cancer. So B cell markers include CD10, remember CD19, 20, 21 as well. There's also a correlation with this CNS lymphoma and HIV/AIDS. Any other immunocompromised state can predispose you. Again, Epstein-Barr virus is found very, very widespread in the genome of these different CNS lymphomas. And there's a bit of a differential here. If you see this if you catch it on an axial MRI, it's going to look like a soap bubble lesion. It's going to be one ring-enhancing lesion. So something like toxo might be in your differential there. And remember, as toxo develops, it'll typically develop multiple ring-enhancing lesions with that soap bubble appearance, whereas a CNS lymphoma tends to just be one single mass. Okay. It's got an angiocentric distribution, and I could see this question or this histology, this pathology, I could see them giving it to you and just using it as a gateway to ask an Epstein-Barr virus question or an HIV virus question. That classic angiocentric distribution, that is an easy diagnosis. Germ cell tumors. You don't need to know too much about this right now. This is not very high up on the priority list of things that they want you to know in block 3. What you should recognize for now is that alpha fetoprotein and beta human chorionic gonadotropin are things that have to do with reproduction and baby and mommy, okay? So when baby's growing in mommy, there's a lot of beta HCG, and then AFP should be going up as well a little bit. And then if you have AFP or beta HCG going up, in someone who's not a pregnant woman, well, then that's really bad, because that typically means there's some cancer inside your body that's making AFP or HCG, okay? And so these cancers are of germ cell origin, and that germ cell is just we're going to call it a germ cell if it originates in this germ cord, which is kind of just a cylinder or a column of stem cells that's right in the midline of the trilaminar disc at about week 3 of gestation, okay? And then this column of germ cells separates, splits in half to form 2 genital ridges. And then those genital ridges are going to move downwards, and they're going to become eventually basically the ovaries in women and the testes and the seminiferous tubules in men. So that's where you get your sex organs, from these germ cells, and you can get germinomas from those germ cells. Now, we're going to call it a germinoma if it pops out of a sperm in men or an egg in women. And then if it pops out of any other related stem cell that's not a sperm or an egg, so a diploid cell, because sperms and eggs are haploid. So if it pops out of a diploid stem cell, then we're going to call it a non-germinomatous germ cell tumor, okay? I didn't explain germinoma very precisely there, but that's not the point. The point is, you don't need to know that much about germinomas right now. Meningiomas are ventricular tumors that originate from arachnoidal cap cells. You might also see these called meningoepithelial cells. There is an association with NF2, okay, which is an autosomal dominant disease with bilateral acoustic schwannomas. They like to ask that. These meningiomas often cause hydrocephalus because they're growing into the ventricles, but we're going to mix things up a bit. This is hydrocephalus in an adult this time. The median age at diagnosis is 65 years old in the meningioma. Now, radiation therapy for a prior cancer is a big risk factor for the development of a meningioma. Maybe you had a thymoma or a thyroid cancer or a lymphoma, and they zapped you with some radiation, and then eventually you developed a meningioma years later. That's usually how it'll go. This is technically a tumor of the dura mater, and they like to tell you how it's got a dural tail or a dural attachment. Here it is in this caption, dural tail sign, right? That just means that, so when we say dural tail, this is what we're talking about. You see this little spike up here, right? This little flippy thing that kind of looks like a cowlick, you know, like when the back of your hair, you got one little part of your hair that's just sticking straight out. That's what this part of the tumor looks like. Am I right? You know, it's just kind of sticking straight out there. So that's a dural tail. And what that means is that this tumor is of dural origin. It's not from the brain. It's not of the parenchyma of the brain. It's from outside the brain. And technically, it is growing into the brain from the outside. So that's the meningioma in a nutshell. What do you see on histology? Let's take a look at it. You see whorls, okay? Like it's wavy. It's a wavy dude, okay? This tumor is not a straight line guy. Some people like me just wake up in the morning and got to go to the gym, got to make my coffee, got to make my breakfast, got to sit down and study, got to go somewhere, got to do this, got to do that. This tumor is not like that. This tumor is so calm. This tumor is just enjoying life. This tumor is going with the flow, and it is just being wavy, dude. Man, I bet this tumor says man a lot, man. You know, man, yeah, like that's the kind of tumor a meningioma is. Just chilling. Got some whorls here. Kind of curvy. Not too straight line. You can't make me stay in a straight line. Nah, man, not like that, man. Life's not like that, man. That's a meningioma for you, okay? So you see a bunch of these spiral-like whorls. That's a meningioma. And then there are psammoma bodies in there too, which are calcified spheres. They're just calcium. And they've got these ring-like structures like onions or jawbreakers to them. If you cut them in half, you see rings inside of rings inside of rings. Those are psammoma bodies. Get very familiar with them. More Psammoma bodies here. They stain very bright eosinophilic. This is the only tumor that's got Psammoma bodies in it. This is the only CNS tumor that has Psammoma bodies, and the only CNS tumor with these little whorls to it, okay? Question, a 66-year-old woman shows up at the ED after having a seizure. She's had visual deficits the past 3 months. She's become apathetic and inattentive. You take an MRI, and you see a space-occupying lesion that is hyperdense compared to the brain, and it's growing kind of between the brain and the skull. So you're suspecting a dural tumor. You take a biopsy. There are whorls of fibrous tissue and calcified concentric rings. So what's the question? What's the cell of origin? And the answer is the meningoepithelial cell. That's how that gets asked. Similar one, a 50-year-old woman shows up complaining of headaches on the right side of her head. You take an MRI and you see a tumor arising from the arachnoid. So then the question is, what do you see on histology? And the answer is Psammoma bodies. So that's your meningioma. You really don't need to know these classifications. I don't want you to go spend hours on top of hours learning the classifications of these meningiomas. Be able to recognize one when you see the whorls that look like thumbprints and the Psammoma bodies. They tend to be spindled. They tend to have that kind of a connective tissue appearance to them because, again, they do arise out of the dura. They will stain for vimentin and fibronectin, which are kind of connective tissue proteins there. They don't stain for GFAP. One more time, that neurofibromatosis 2 association, particularly with the Merlin gene. And that dural tail we talked about. So brain metastasis likes to show up at the gray-white junction. The most common primary site is the lung that might show up. Gray-white junction, I remember, definitely did. There's the gray-white junction, right? Here it is in these 3 images, A, B, and C. So you got some white matter, got some gray matter. Right in between is where you get metastases. And then paraneoplastic syndromes. I remember spending like an hour on this way back in the day, and then it didn't show up on a test. And, you know, if it does, well, then they're going to tell you, hey, like one of the answer choices will be paraneoplastic syndrome. So it's like, come on, man, they give you the answers. So you don't need to know. You do not need to know these like the back of your hand, okay? Some paraneoplastics you do, like SI-ADH maybe, or like maybe myasthenia gravis with a thymoma, or maybe something like PTHRP with a lung cancer, but these are not of the utmost importance. And that's it for that second brain tumor SDL. I want to just re-emphasize that you don't have to know these. This is breadth, not depth, okay? You have to have a broad understanding of brain tumors, but you do not have to go very deep under the surface of every individual one. They want you to know classic presentations, and they want you to be able to tell similar tumors apart. For example, the Ependymoma versus the Medulloblastoma, both of those posterior fossa, fourth ventricular tumors in a kid. Be able to tell them apart. That's all I got to tell you. So a whole lot of histo. Please reach out if you have any questions, but I know that you'll be pretty good. Thanks very much.